Okay, so we just wanted to have a quick discussion related to cortisone-based treatment as an option. It's a question that we get asked a lot in the clinic, so it's something that we wanted to get someone to come in and speak into who knew a lot more about it than we did. So I'd like to introduce Dr. Lee Golding, and Lee, if you could just tell everyone a little bit about yourself to start.
Yeah, thanks very much. So, yeah, my name's Lee Golding, and I'm a registrar in sports and exercise medicine. And I practice in ortho sports, and there's a clinic down in Hurstville that I consult out of. I consult out of Randwick, and another clinic called Sutherland Sports Injury Clinic.
So with cortisone first, I guess, just for everyone out there who has a little bit of an idea on cortisone, could you just explain cortisone from your perspective of not so much going into its benefits, but just its uses and where it came out of, I guess?
Yeah, it's so cortisone is an injectable medication. It's known as a glucocorticoid. So it's technically a family of steroid medications, but not anabolic steroids in the way that you typically think of them.
It's good to differentiate that because people get that a bit confused.
Yeah, definitely. It's essentially a potent anti-inflammatory medication. So it's used primarily to reduce inflammation at the site of injury, and thereby produces a reduction in pain when it's injected.
So with cortisone, there's often when we're suggesting it as a possible treatment option, there's so many negative concepts of it and concerns about it. What are the valid concerns about cortisone injections?
Well, firstly, I think you have to consider that any interventional procedure like that does have some risks associated with it. Any injection, there's always a risk of infection. The absolute risk is actually very, very low. It's 1 in 10,000 or less, so it's extremely rare. Most of those infections can be treated easily enough, as long as they're not infections into joints. Depending on where you're injecting as well, there's always a risk of injecting nearby vessels. So some injection sites are less risky than others, but very, very rarely you can inject a nerve or a blood vessel or something like that. And in the vast majority of cases, if that even does happen, the recovery is actually very good and has little impact. And those sort of instances are very rare, but they can happen with any injection. In terms of specific risks for cortisone itself, when you're injecting into joints, there is a theoretical risk that multiple cortisone injections may accelerate the rate in which you lose cartilage.
Okay.
So for that reason, we're a bit hesitant to put multiple injections into weight-bearing joints like the knee, for example. The research is not all that agreed as to whether that happens or not, but we take a cautious approach with putting cortisone into weight-bearing joints, just for the worry that it may be that multiple cortisone injections may accelerate the rate of cartilage loss. In terms of injecting them into tendons, some tendons are safer than others. We get particularly worried about injections into big tendons like the Achilles tendon, because there has been studies that demonstrate that we may be at increased risk of rupturing the tendon, and to rupture a big tendon like your Achilles has a significant impact. So most of us as sports doctors wouldn't ever put a cortisone injection near the Achilles anymore.
Right.
Yeah.
Basically a flat rule.
Well, most of us, you can inject around the paratenol, so around the side of the Achilles, but still you'd be a bit cautious in who you selected that for. But other sites and other tendon sites are a lot safer.
So mainly the bigger weight-bearing tendons, I'm assuming, are the big concerns.
Yeah, in general. The risks with cortisone as well that you need to consider. There's a decent research paper that was published on Tennis Elbow a while ago that showed that while it can help a significant amount of patients in the first instance, that maybe at the 12-month mark,
further down the track,
the guys that didn't have the cortisone may be better off. So you have to pick and choose your patients. You have to pick and choose what tendons you're using it for, and what the demands of the person that's having it are.
injectables, as you were saying. And another thing that's, I guess, a little bit more recent from our point of view from cortisone, I don't know if it's been around a lot longer than cortisone, but PRP injections. Could you just explain those a little bit for us?
Yeah, so as a general overview, PRP injections stands for platelet-rich plasma, and the process involves taking a small sample of your blood, so usually that's from about 30 mils to anywhere from 60 mils, so 1 or 2 shot glasses worth. And we prepare that there's various commercial kits that are available, and you prepare it in a centrifuge, so essentially the heavy red blood cells, the erythrocytes, fall to the bottom, all the light plasma proteins and things go to the top, and in the middle you're left with this layer, the platelet-rich layer, that contains all the growth factors and the things that help accelerate the healing process. So we extract that and inject that back into the person that's come with the tendinopathy or the arthritis, for example. And there has been some good research to show that it does help improve pain and improve function for certain conditions, common conditions like osteoarthritis, like tendinopathy. There's some good research out there now to say that could be useful. The main advantage that PRP has in certain indications is that it doesn't cause that rebound flare of tendinopathy, and there's no evidence.
We see that with cortisone.
Yeah, so there's no evidence that it also will accelerate cartilage loss or anything like that. So some of the concerns that you think about with cortisone, you don't have those disadvantages with the PRP. So it's been a very useful medication, something that's been around in sports medicine for 15 plus years now, so we're experienced with it and kind of have good evidence of where to use it and when not to use it.
The other thing I guess is good to discuss is you know, if a patient does go down the path of an injectable of cortisone, the importance of the adjunct of strength work and loading of that tendon for the rehabilitation. Often that's something that's not done well within our industry, I find, as physios dealing with tendons, about progressive loading and how to well load and how to unload also. But just if you could just talk about the importance of load management of a tendon in conjunction with cortisone.
So, happy that you mentioned that. It's ultimately the cornerstone and the main thing we need to get right when we're rehabilitating people for tendinopathy. The injectable therapies we can use as an adjunct, so maybe the last 10 or if you're lucky 20%, but the cornerstone of getting these better is gradually reintroducing load. First of all, offloading them until pain dies down, and then introducing appropriate rehabilitation and exercise and gradually rehabilitating that tendon over time. Sometimes a cortisone injection will allow things to settle down in the first instance to allow people to start that progressive rehab. And in other times, if they've plateaued a bit away along their recovery, there could be a role for injectable therapies there. But there's no getting away from the fact that the rehab is the most important thing. And we'll get most people by. Most people do not need injections for tendinopathy or osteoarthritis. They can get by with good rehabilitation for most of the time. Well,
Lee, thanks so much for coming in firstly, but also just to let everyone know how, if people want to come and see you for your opinion, how do people go about that?
So at the moment, I'm consulting at Orthosports. So if you go on the Orthosports website, there's details about how you can make an appointment with me, and Sutherland Sports Injury Clinic as well. Their website, you can get booked in with them, and that'll be easy enough.
Perfect.
No referral required.
It's one of the best parts. Again, thank you so much, Lee.
My pleasure. Thanks very much.